ultrasound or sonogram, this is not the therapy ultrasound, but this is the diagnostic ultrasound, where the detector here, you're going to place basically, and you always want to do the same thing. So all of your exams are the same. You'll put the cord on the proximal side, and right here you can scan. Have the patient hold the foot in dorsiflexion. Here, use a little ultrasound gel, of course, and take your image basically right here, measuring, and you can scan across and you'll get yourself a good image. But basically you want to capture right in here the plantar calcaneus, the fascia insertion, and you're measuring and you're available to see the fascia insertion area, the bottom of the calcaneus, and be able to take a measurement in this exact space. So with the ultrasound of the foot serves both as proof of the plantar fasciitis and a demonstration of how bad is it. So on the picture you will see, and I did my own foot and I measured it to be 5 millimeters. There's studies out there between 3 and 3.5 millimeter thickness of the plantar fascia insertion as normal. So my 5 millimeters would certainly say that the fibers are not nice and tight, standard 3 to 3.5 millimeter. They've got some scar tissue, they've expanded. So prone to have plantar fasciitis. Now, that doesn't mean that I have the plantar fasciitis, the inflammation. I currently don't have any pain. It's more of a fasciosis. So there is a damage, there's some scar tissue in the fascia itself. I've seen many marathon runners or very active patients or severe overpronators with a fascial thickness of a 10 millimeter. That's about the biggest I've ever seen, but they can be pain-free. They're just always at a larger risk because of the chronic damage to the fascia. So one, it's a diagnostic tool for the patient to say, yes, you have plantar fasciitis or fasciosis, let's say, and it proves to them, hey, there's a problem with the fascia. It's not a 3. Okay, as you look a little further distal, you'll see the fascia narrow out, and usually about 2 millimeters as it narrows out past the insertion area. So anything outside of that, you have fasciosis, you have damage. You have to look and say, hey, do you overpronate? What's causing this chronic damage to the fascia? So it leads into the discussion of the therapy, the support, all the rest of it. So it is a diagnostic tool, but it wakes up the patient to be able to see, hey, how much damage do I have? Okay, there's proof of this damage. Now let's move forward from there. Conversely, if someone's in severe pain and you go into the sonogram feeling like, wow, this is going to be a really big fascia on this scan, and it turns out to be normal, well, then you need to start looking at some of the other variants and say, okay, well, the fascia is pretty normal, pain is higher. I need to look at some alternative diagnoses, or an MRI, or see what else might be happening because the fascia was unexpectedly normal in that case. So use the diagnostic tool of ultrasound, one, confirming a diagnosis, but as a demonstration to the patient of the severity and how much work they're going to need to put in with regard to office therapy, home therapy, and continued support, whether it arch support, sandal support, or all of the above.